Alright, so we look at here through a normal artery and with narrowing of the artery and with the information that we've gone through before about the decrease in radius size. So we're going to know that this is going to have increased peripheral resistance. Increased peripheral resistance is going to result in increased blood pressure. And what's also important here is seeing that this structure here is actually the intima. This is where blood flow is going to go through. That the plaques are subintimal. They're underneath the intima, between the intima and the medial layers. So you can't just go in and squeeze out the plaque or scrape out the plaque. It's not that easy, because if you're trying to scrape the plaque out, what you're going to have to do is rip out the intimal lining, which is going to stimulate platelet aggregation, clot productions, etc. Right, so to overcome that increased resistance, we must increase in size. It's a muscle, so you get ventricular hypertrophy. Ventricular hypertrophy is going to increase myocardial oxygen demand. Increased oxygen demand, typically with stenosis, you can't have increased consumption, so you might result in some chest pain. And again, ischemic muscle does not function as normal muscle, so you're going to start a little spiral of congestive heart failure. So treatments, number one should be lifestyle modification, including absolutely stopping smoking and exposure to tobacco. Decreased stress levels, which we've talked about in class. Increased physical activity, both aerobic and anaerobic. The dietary approaches to stop hypertension, including increased intake of magnesium and antioxidants. Increased moderate red wine or grape juice intake. Decrease your saturated fat and cholesterol. Decrease your sodium levels. And we've seen that the non-pharmacological effects of a combined lifestyle modification can usually bring a lot of patients down to normal blood pressure, right? 5 plus 8 is 13, plus 4 is 17, plus 2 is 19, and that's being conservative for weight reduction. And again, all of these have no contraindications. There's no contraindication to weight reduction, no contraindication to increased antioxidants and increased fruits and vegetables, no contraindications to physical activity, no contraindications to moderate ETOH. When we look at pharmacological, we can look at either diuretics, ACE inhibitors, ARBs, direct renin inhibitors, calcium channel blockers, beta blockers, vasodilators, statin drugs, the entire drugstore. This looks again at hypertrophic muscle, decreasing that lumen, decreasing the amount of blood that's in the left ventricle that can be ejected out, so that decreases your stroke volume. We've talked a little bit about endothelial dysfunction. It's a term that you're going to need to understand the entire pathophysiology of high blood pressure. That the endothelium secretes both vasoconstrictors, vasodilators. When it's healthy, it secretes substances which prevent clots. When it's stressed and diseased, it secretes substances which promote clots. Okay. That these oxidative stressors, when the intimal lining gets oxidized, when it's healthy, it secretes nitric oxide, right? Potent vasodilator, antiplatelet agent. When it's oxidized, it promotes the death of endothelial cells by augmenting apoptosis, and it decreases the availability of nitric oxide, which also increases adhesion of monocytes, remember macrophages, to the endothelium. If we go back and look at salt's impact in high blood pressure, the results aren't exactly the clearest of any substance studied. In the U.S., we average about 9 to 12 grams of sodium per day, even though the American Heart Association recommends less than half of that. Most of the salt in our diet is already included in the processing. It's already in the soup can, it's already in the meats, it's already in the preservatives. So just having a patient stop using their salt shaker, not the biggest indicator and not going to get the best results. You really have to try to augment and go to that low salt processing. Obesity, taking a look at the patient's waist to hip ratio, which you can do at every ambulatory meeting. Looking at things like central obesity for the abdomen and hip fat and belly fat, which is going to increase insulin resistance. Increased insulin resistance means more insulin is going to have to be released to try and keep blood sugar normal. Remember that insulin is a fat storage hormone. That's one of its primary functions. So if you keep having to secrete more insulin to keep your blood sugar at normal levels, then insulin's going to have that side effect of constantly increasing, especially belly fat and abdominal fat. Alcohol, we tend to have a straight and narrow line with that 2 drinks or so a day is cardioprotective, and then you get to 3 drinks a day or day, and that becomes cardiotoxic. Again, diets high in potassium are usually low in sodium, and calcium, magnesium have roles in smooth muscle contractility. Again, looking at things like secondary hypertension, have an identifiable cause. You can have an adrenaline-secreting tumor, a pheochromocytoma, renal artery stenosis, cocaine, sleep apnea. These can all be addressed, and when they're corrected, the blood pressure should come back down to normal. Here's again taking a look at that renal artery stenosis, sort of little rat bites out of the renal arteries. You decrease the blood flow to the kidney, and you're going to start the renin-angiotensin-aldosterone cycle again. Now, this is looking at papilledema, looking at through an ophthalmoscope, looking at the changes in the vascularity and the blood supply of the eye. So hypertension is really a blood vessel disease throughout, affecting the kidneys. You get nephropathy, hypertensive nephropathy, hypertensive retinopathy, increased risk of strokes, CVAs, TIAs, etc. So again, what can we do? Things like diuretics, Lasix, hydrochlorothiazide, beta blockers, the metoprolol, the atenolols, your ACE inhibitors, your ACE receptor blockers, and then there's DRIs, which are direct renin inhibitors, calcium channel blockers. We move from hypertension over to congestive heart failure, which is a clinical syndrome featuring dyspnea and retention of sodium and water, which results from differences in the contractile ability of the heart and changes in preload and afterload and changes in heart rate. So if we go back and look at the anatomy of the heart, we understand that the left ventricle ejects blood out into the ascending aorta. Okay. So if the left ventricle is under additional stress, we understand that most myocardial infarctions affect the left ventricle. We've talked about left ventricular hypertrophy and left ventricular dilatation before. So if we know that the left ventricle is undergoing a lot of stress, well, if the left ventricle is not pumping that well, where's blood going to be stored and back up into? And the answer is going to be the left atrium. So left atrium is going to enlarge, and where's blood going to try and get into the left atrium? Well, blood gets into the left atrium from the lungs. So the left-sided heart failure is really where you're going to get this pulmonary edema, because blood's trying to come into the left atrium. It's getting backed up. The pressure in the lungs is going to increase, and that's going to cause some transudates, which means pulmonary edema. It's fluid in the alveoli. If we look at right-sided failure in the right ventricle, well, blood from the right ventricle goes through the pulmonary trunk and into the lungs. So if the right ventricle is stressed out, and we see this commonly, we'll talk about it in the next lecture about respiratory, things like cor pulmonale and people with COPD and increased pulmonary vascular resistance and pulmonary hypertension. If the right ventricle is in failure, well, that means blood's going to be pumping up into the right atrium, and blood goes into the right atrium typically from the superior vena cava, inferior vena cava. It's more peripheral. So you'll see that JVD, the hepatosplenomegaly, the ascites, the peripheral edema. Tests that we can look at for CHF, again, you want to look at the EKG, which measures, I keep saying K, it's ECG, which measures electrical activity. Echo, which is going to look at the function of the heart, and that'll show you things like reduced ejection fraction, akinesia or dyskinesia of the heart muscle wall itself, if there's a papillary rupture, if there's a valvular issue, if there's vegetation on the valves, if there's endocarditis, maybe what the underlying cause is, if it's not just long-standing high blood pressure. Chest x-ray, you're going to look for cardiomegaly and pulmonary infiltration. For the blood test, your blood tests would typically come back normal, maybe an elevated sodium level, but what we're really looking for is BNP, which is B-type, sometimes called brain natriuretic peptide. This is released by the atria when they're being stretched. And it accomplishes pretty much the opposite of what ACE does. Remember that angiotensin is trying to increase your blood pressure, thinking that you're dying because the kidneys aren't getting enough blood or it's sympathetic stimulation. Well, natriuretic peptide is released by the heart and actually does the complete opposite. It's going to try and bring down your blood pressure. It's going to try and excrete more fluid because it knows that it's being stretched, right? If the atria are being stretched, that means the ventricles haven't done their job. Cardiac enzymes, if it's just straight congestive heart failure, should be fairly normal. Remember, cardiac enzymes we're really only going to find secondary to heart muscle death. But as you all know, patients coming in with MIs, it could either have the pretty much the MI that broke the camel's back, and now they're in full CHF secondary to an MI. But if they haven't had any recent cardiac muscle death, then cardiac enzymes should be relatively normal. So I'm going to stop here, try and post this.